Over the past few years, the advances in vitreoretinal surgery have encompassed improvements in visualization and microscopy, advances in 25 and 27 gauge microsurgical instrumentation, and the use of better illumination and vital dyes. Almost simultaneously, OCT has transformed clinical practice, and the integration into the operating room is the next paradigm shift for better surgeon decision making and altered patient outcomes. Intraoperative OCT adds a new dimension of visibility. It helps in difficult cases and certain steps of standard cases both in anterior and posterior segment surgery. And since most surgeons always request OCT before and after surgical procedures, intraoperative OCT forms a natural progression to identify endpoints to verify the achievement of surgical goals. The most common use of intraoperative OCT has been found in the treatment of macular holes and the management of epiretinal membranes. The Discover study comprised surgeons with all levels of experience, yet still found 14% of peels were incomplete based on AIOC data. The study further showed that in 11% of the cases, surgeons believed additional peeling was required, while AIOC data showed adequate peeling had been achieved. Similar results were also seen in the Pioneer study. Our use of intraoperative OCT has helped us in differentiating pre-existing from iatrogenic retinal lesions, including those in the far periphery. Intraoperative OCT is also invaluable in planning membrane segmentation. Intraoperative OCT allows us to differentiate neovascular membranes from the underlying retina and hence prevents the formation of iatrogenic retinal breaks. While direct visualization of the retrolental space of Berger is possible, intraoperative OCT gives us a fantastic view of the posterior capsule of the lens. This serves as an additional tool in the surgeon's armamentarium. This sort of visualization also allows us a no-holes barred access to the posterior surface of the lens and is especially useful in clearing heme stuck to the posterior capsule. With the advent of sutureless vitrectomy, intraoperative OCT conveniently allows the surgeon to visualize adequate closure of the sclerotomy port. AIOC also conveniently allows us to visualize peripheral anterior synechiae. This allows the surgeon to alter management intraoperatively. The proper uptake of endolaser burns at the level of the RPE can also be visualized by intraoperative OCT. This is visible as tiny blebs or reaction at the level of the RPE. While visualization of reaction at the level of the RPE is not absolutely critical in the use of standard green laser, it may prove very useful with the advent of micropulse laser. Intraoperative OCT is also able to capture excellent visuals in the presence of air in the posterior chamber. While intraoperative OCT is fast gaining momentum, a few drawbacks are hard to ignore. Presence of additional OCT information in the microscope oculars may cause a distraction to the surgeon and cause disruption of normal workflow. Also, with any new technology, it's hard to ignore the cost. Research into instrument materials that do not cast shadows is also underway. Surgery is a dynamic process, and intraoperative OCT allows us to study the architectural changes occurring during surgical manipulation. OCT has already revolutionized the clinical practice of ophthalmology. And by using intraoperative OCT in real time as you reach and perform maneuvers, it is poised to become a viable adjunct to ophthalmic surgery.